Hello. For those of you who don't know me, my name is Dr. Joey Grover, and I'm the medical director for Orange County Emergency Services. We're going to be talking about CPAP today. And the reason for this lecture is really because this is one of these most important interventions that can be performed in a respiratory distress patient early on to have the greatest impact in terms of their overall care. And so the hope is that with this additional information, we can have greater utilization of CPAP in the pre-hospital setting prior to EMS arrival. So what are we going to talk about today? We're going to talk a little bit about the overall assessment of our respiratory distress patients. We're going to talk about the overall mechanism of action of CPAP. We're going to talk about some of the differentials for that respiratory distress patient, and of course, address why CPAP is so helpful. So one of the things that we always talk about when it comes to our respiratory distress patients is how important just their general appearance is, right? We all know those patients who say they're short of breath. You arrive on scene, they're running around the scene, they are talking up a storm, and you clearly know that they are in no respiratory distress. But the fact of the matter is, there's a lot of other subtle hints that we can find when it comes to that patient assessment that are so important in recognizing the truly sick from the non-sick. So when we think about their overall respiratory distress, right, are they overall using additional respiratory muscles, right? We talk about these accessory muscles of breathing, right? Do you see that they have pursed lips? Are they leaning forward, doing what we call tripoding, right? Do they, when you listen to them, not even have appreciated breath sounds, right? Because they're moving so little air with each breath that you don't even appreciate that they're moving air at all, right? Similarly, do you know other signs of that they're not breathing adequately, right? Do they have what we usually will describe as clubbing, right? Or these kind of very large blue distal fingertips, right? What about just in general, right? Do they just have what you would describe as the overall discomfort appearance, right? Are they diaphoretic? Are they tachypnic, right? All of these are really important physical exam findings as part of your assessment that clue you into a patient who's truly sick as opposed to a patient who may not be, right? When we think about their overall assessment from a lung sound perspective, right? Do they have wheezing? Do they have crackles? Or do they have completely normal lung sounds when you listen to them? When we think of wheezing, we think of that obstructive lung disease pattern, right? Those are the asthma or COPD, right? Those are the patients who have what we describe as kind of that prolonged expiratory phase, right? That really long expiratory wheeze, right? As opposed to a relatively quick and normal expiratory phase, right? Right? Quick inspiration and expiration. How about crackles? When we think about crackles on lung exam, in that patient with heart failure, right? That could be fluid. It can also be signs of a pneumonia, right? Is it just like a pussy junk in their lung space that's causing that crackle sound? And so part of the goal here is when you find that there are enough physical exam findings to suggest that they are in respiratory distress, the key is for us to act quickly, right? And intervene. And that intervention can be oxygen, right? If they're hypoxic. But I'm going to be arguing for thinking about an earlier intervention with regards to CPAP for most of the commonly encountered respiratory distress patients, right? And so when do we act quickly? When they're showing that respiratory distress phenomena. And then, of course, if they are hypoxic, just based on the number we're obtaining. So why doesn't oxygen help sometimes, right? If I'm just telling you that they're hypoxic, that their oxygen number is low, why not just give them oxygen? That'll fix the problem. Well, unfortunately, due to a number of different conditions, giving them oxygen alone may not improve their overall respiratory distress, right? So this is a little bit of an anatomy 101 course. When we think about how we get oxygen into our bloodstream, it all occurs at the alveoli, right? These are those little sacs at the end of our airways where all of our gas exchange occurs. And there's blood vessels, we call them capillaries, that run along it. And then think of them like little balloons that are basically inflated adjacent to these blood vessels, and the oxygen and CO2 get exchanged at that point. Well, unfortunately, due to a number of different conditions, sometimes that alveoli can collapse. So say it's filled with fluid. If there's a fluid that's collected between the capillary and the alveoli, then there will be no gas exchange that takes place. Similarly, if they're not adequately ventilating, so the oxygen, so the sac is collapsed because of no air getting into it, that will also be a situation where there will be no gas exchange. So you could put as much oxygen all you want, in their mouth, and nothing will get down to that lower airway where the alveoli are in order to allow for gas exchange. And so the question then is, how do we get air where it needs to be, right, in that alveoli, prevent it from collapsing, and better allow for that gas exchange to occur, right? When there's fluid in that space, once again, those alveoli collapse and they won't inflate. And the amount of force needed to get that alveoli to fully expand is higher than what those people are normally doing with just simple respiration. And so the question then becomes is how do we get additional airway pressures into their mouth in order to get that balloon to expand, right? Think of it as trying to expand a balloon in Jello, right? You blow as hard as you can onto that balloon, nothing happens. But if you connect, a leaf blower to the outside of that balloon's going to expand, and it's going to push against all that Jello in order to allow the balloon to fully expand. And so that's what we're trying to generate is enough force to overcome whatever fluid or other external force that's preventing that balloon to expand. In obstructive lung disease, it's a little bit different. Because of the swelling of the airway, you get airway collapse. And so not enough air can go through that tiny little pinhole in order to get to that distal airway. And so similarly, right, if you can't get enough air through because it's a little pinhole, if you increase the amount of air pushing through that pinhole, you'll get the air to travel farther and get into that distal airway. So what is CPAP? It stands for continuous positive airway pressure. And so all it does is basically provide a continuous amount of force into the mouth, right? Pushing air into the deeper airway. And the hope is that you're reaching those smaller airways, right, all the way down and down to the alveoli, right? In terms of the amount of force that we generally generate with a CPAP device, it's somewhere in the ballpark of 5 to 15 centimeters of water. And understanding that a standard airway pressure is generally around 5. So in Orange County, we set ours at a minimum of 10 because the understanding is that if you start at 5, you're probably not accomplishing much if that's the standard airway pressure, right? And so once again, you're providing a continuous airway pressure. So it doesn't alternate based on inspiration or expiration, but every time they take a breath in, you have the air that they're taking in, so the force that they generate, in addition to the continuous positive airway pressure that's provided by this device. And then when they exhale, right, and that additional force from the inspiration goes away, there's still that continuous positive airway pressure. So you create a minimum baseline as opposed to, right, where your normal airway goes up and then down to 0. Here you're creating a force that's above that and continuing the pressure. And the hope is that continuous pressure will allow those alveoli to still stay open. So you don't have to keep addressing the fact that they've collapsed. If you keep the alveoli fully expanded, then the hope is that gas exchange is easier to occur. So once again, how does this help in some circumstances? So pulmonary edema or pneumonia, where there's a fluid collection there, basically creates a barrier between where the capillary is and where the alveoli is. Similarly, those alveoli collapse. And so what you're doing is generating enough force to actually hopefully force some of that fluid away from where that gas exchange occurs. The thought is it may actually force it somewhat into that vasculature so it gets absorbed. And in addition, it also allows for that balloon to get expanded. So once again, at the alveoli level, you've expanded the alveoli and now it's able to perform gas exchange. So how about an asthma or COPD, which are the most other common causes that we have for respiratory distress? So one of the things is that it actually overcomes that airway resistance, right? So if the airway is already really constricted and there's only that little pinhole, you're going to get enough air pushed through that tiny pinhole to adequately ventilate at the alveoli level, at those distal airways, right? And you're going to prevent them from collapsing. Because if you continually provide a force of air through it, the overall airway won't have time to collapse. And then the thought is if you are giving albuterol other treatments, if you're able to get them farther into the airway, you're going to have a greater effect. And so just by having them propelled with all the force of the CPAP, the hope is you actually are able to better deliver those medications when they're being given as well. And so the question is why is this helpful, or does the science really support it? This is a long known benefit in terms of using CPAP, or what we call non-invasive positive pressure. So this dates back to a big study in one of the top medical journals from 1998, which basically showed that using CPAP or BiPAP can significantly reduce the needs for intubating these patients. So suddenly you're reducing their total hospitalization, right? You're preventing them from having to get admitted to the intensive care unit, and you're relieving the respiratory distress with these devices. So highly effective, highly beneficial, and have been shown to reduce death and duration of hospitalization. So going back to your overall assessment, you arrive on scene of a patient who's in respiratory distress. The short answer is most of the reasons for those respiratory distresses are going to be addressed with CPAP. So if your exam findings show that they've got swollen legs, or they've got JVD, right, or they've got crackles on their lung exam, all suggesting either a pneumonia or a heart failure picture, right? The good news is that CPAP will be beneficial in those settings, right? If you listen to their lung exam and they're not moving air and they've got a history of asthma, right, and they tell you this is just like their prior asthma attack, absolutely this will be beneficial. And a simple non-rebreather is not going to be that helpful for that patient, right? Similarly, if it's not asthma or COPD, but heart failure or vice versa, the good news is the same intervention of CPAP is going to be helpful, right? So what are some of the common indications for CPAP? So CPAP, so CPAP, you can use that as an acronym. So CHF or COPD could stand for the C, P for pulmonary edema, A for asthma, and P for pneumonia. And so the short answer is all of these conditions benefit from the CPAP intervention. So what are contraindications? Are there situations where I just don't want you to put CPAP devices on? Well, there are a couple. So the first thing is protection of their airways. So if their mental status is bad, right? They are lethargic, too sleepy to respond to questions. The concern is that if they were to vomit, they wouldn't have all the innate protections to know how to prevent it from going into their airway. And so you're basically forcing air into their face. All that vomit will just go into their lungs. And so they'll aspirate. And so for a patient with a poor mental status, that is not a patient that we want to put on CPAP. Similarly, if they're not breathing. So remember, CPAP doesn't alternate based on inspiration or expiration. It's just that continuous force. And so if they're not breathing, you will not get them to breathe with a CPAP device. So in that situation where they're just not breathing at all, you need to bag valve mask ventilate them to be able to get them to ventilate. Similar to the first example, if they're actively vomiting, we do not want to put them on CPAP because once again, that's going to lead to aspiration. And then the final category are patients who have facial trauma. And the concern there is that you're going to cause more harm by placing them on CPAP given their degree of facial trauma. Similarly, a lot of times the seal won't even be able to be obtained, right? If they have a broken nose, the seal around the nose won't work. It could cause a lot of pain. And then once again, having air pushed into an area where they already have facial injuries, you can lead to actual air accumulation in the face itself, which could be quite harmful. So once again, for facial trauma patients, we do not recommend these treatments. And so once again, the thing I want to emphasize is that this is an effective treatment for most causes of respiratory distress. Pulmonary edema, CHF, COPD, asthma, bacterial pneumonia, viral pneumonia. All of these indications are beneficial with regards to giving them CPAP. And so the goal here is to transition from a non-rebreather, so thinking only just giving oxygen, to really thinking about the overall cause to their respiratory distress and addressing it appropriately with CPAP. Rapid CPAP intervention has been shown to have tremendous benefits for these patients long-term in terms of their hospitalization, reducing their chance for intubation. And so the earlier we can administer this, including prior to EMS arrival, the better these patients will do. So once again, think about what conditions are most beneficial and whether or not the condition that you're encountering you think would benefit from a CPAP intervention. CPAP, 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 if you have a patient in respiratory distress. If you put them on a non-rebreather, your next thought should be, let's get the CPAP ready. And so once again, almost all of the conditions you're going to encounter would benefit from a CPAP. Thank you so much. I really appreciate your time. We're now going to show you a video to show how to apply a CPAP device on a patient. Once again, thank you so much for taking the time to watch this video.